Dissociation, I want to emphasize, is a strategy for survival. Those of you who are doctors learned early on in your careers how to keep calm in the face of emergencies. If you're carrying out an operation and something goes badly wrong, there's blood all over the place, you can't burst into tears. You can't stop what you're doing, get on with your grief. You have somehow to bottle up your feelings, get on with it, don't you? And it's similar ways firemen and police, faced with emergency situations, quite deliberately clamp down on their feelings. And we have a measure of control over this. Problems arise, of course, if it goes on for too long, when people perhaps become paralyzed by fear, may enter into fugue states or have amnesia for the events leading up to the loss. These kinds of dissociation, which are not frequent but do occur from time to time in disaster situations and very traumatic bereavements. I remember one man, a policeman, who went to his first road traffic accident, and he said, you know, while I was there just taking the evidence and waiting for the ambulance and the senior police to arrive, I managed to hold myself together. He said, and after that, I can't remember. I was found 2 days later wandering in the street. I couldn't even remember who I was. These dissociative syndromes, as they're called, they often respond fairly rapidly to admission to hospital, to a place where people will feel safe, reassurance, to a sort of tender loving care which makes people begin to feel safe enough to allow their feelings into consciousness again. Positive reassurance, occasionally using abreaction and other techniques. Dissociative reactions are associated, as I've said just now, with endorphin flooding. Endorphins switch off the frontal lobes to reduce attention and awareness of the perceptual field responsible for emotional numbing and stress-induced analgesia following trauma. And excessive opioids inhibit the formation of explicit conscious memories to reduce recollection of traumatic experiences. We don't have any way of handling these very powerful memories, which we talked about just now in relation to PTSD. But once we've switched off, we can't switch them back on again. So, just summing up on this, it's hard to grieve when one is avoiding thoughts of a death or a dead person. PTSD may be associated with delayed or avoided grief. It may be necessary to treat the PTSD before assisting with the problems of grief and change, although it's quite possible to oscillate back and forth between the two. And I know many psychologists who will oscillate between a session of EMDR and talking with the patient about their memories and so on, helping them gradually to grieve and so on. Dissociative treatments, many will disappear once the patient feels safe enough to relax, and emotional support is the crucial thing here. Psychiatric treatments, including anxiolytic drugs, psychotherapies focused on facilitating and permitting emotional expression, and occasionally abreactive techniques, hypnosis, drug-induced abreactions, are occasionally necessary and may get very, very good results.